All right, so we're going to dive into this quickly, and we do have some slides we'll pull up later. But what's the first thing you guys can notice on this slide? Ignore that. I just want to show. Oh, what's the first thing you see here? Yeah, so anyone that's a tech, this was done incorrectly. Why was it done incorrectly? Yeah, we had the underwire on this wall. So what's that going to possibly cause? Artifact. What else can we tell about this patient by looking at it? They're a little bit heavier. So what are some things we want to talk about here? Basically, when you have a heavier patient, you're going to have a little bit more mass, especially if you have more of a pear shape or an apple shape rather than a pear shape. So you're going to get what? We're going to get all the best images, or we're going to have something like quantum model or photon starvation. Cool. And then we have the additional artifact of what? The streak. Okay, so this study is not going to turn out too good, but with the power of our little photon counting CT, we can see why this CT is great and how it's able to do some work, but it can't really fully surmount everything. So optimizing for your patients, figuring out, okay, if I have a larger patient, where am I going to get them scanned? I would probably do our photon counting and then making sure I definitely remove the bra, and then giving a tighter, larger bolus if I can. And then also emphasizing what? Pre-medication beforehand. We want these coronaries to be what? Dilated before. As we were talking about before, what's going to be our dosage for sublingual nitro? Okay, and what else are we going to give them beforehand? All right, what's the ideal heart rate we want? 50. I've never hit 50. One day. But if I can get them about 60 to 70, that's ideal. Now, sometimes Kristen will call me from the scanner and say, hey, they're a little bit high. Would you rather someone a steady 75 or a 50, 40, 60? Steady. So you want steady. And I know some of our cardiologists, you might not necessarily get the tats from the text, but it's very important to talk to them because they will tell you this type of stuff beforehand. And it's very important to head off a bad scan beforehand versus getting bad data and having to say it's non-diagnostic and having the patient come back. So that being said, what is another thing we can have happen when we're looking at some of these scans? We're going to move on to another case so we can keep showing you guys things. So what is something you notice immediately when looking at this scan? One, they're a little bit heavier. The contrast is there, but what did we say before? You're going to have a little bit of photon starvation. And then also, do you think this person was running at, I don't know, 50 beats per minute or 100, 120? Definitely not 50. So there's a lot of motion here. And we can kind of load this up in the cardiac workflow to show you that briefly. So when I told you guys earlier about establishing dominance early on, I generally try to take the RCA first. One, because that's going to be what most people are, right, dominant. But two, that's the vessel I find to be most compromised by motion and artifacts. So if I can look at that first when my tech might call me and say, hey, is this study good enough to read? I can generally say first off, okay, looking at the RCA, do I have any motion? Do I have too high? Are they too tachycardic? So yeah, it's barely registering this as the RCA due to the amount of motion and due to the poor pacification of this vessel. With the motion there, it's able to track the proximal, but then you essentially lose the vessel. So again, this is just a sort of thing to say, optimize your scan beforehand so you can kind of avoid the pitfalls of tachycardia and optimizing for your overweight patient by having a tighter bolus, maybe a little bit more contrast, and then trying to figure out other ways you can optimize with medication beforehand. You want a steady heartbeat. You don't want a variable heartbeat. So that goes with your patients that are in AFib. If someone's in AFib, it's probably best to do what? Rescan them when they're not in AFib. Cool? Love it. Other things I'll say, as it pertains to the roadmap and FFR, I love tools that make me move faster in my day. However, your eyeballs are going to be the most essential things for this patient. As we've all said multiple times repeatedly, and I've shown you guys looking at the contours, look at your contours, see if you agree with them. At the end of the day, when you do look at the roadmaps, it does give you a little end note that does say, hey, this is an AI preliminary service. But ultimately, it's going to be up to the radiologist, cardiologist to actually verify these images. And there are times that I do not agree with things, and I'll send them back to HeartFlow. We'll get another recon and see, hey, do I agree with it? But ultimately, you guys are really responsible for quality control and making sure these images are perfect and pristine to increase your sensitivity for stenoses and potentially intervention on someone. Make sense? Cool. I know this has been a long day. It is almost 5. I have no other cases to show you.